What I'm going to do over the next 30 minutes is I'm going to try to talk about what we're currently using, how we're using it, and also talk a little bit about the science behind it and how that leads us to new ideas moving forward. Because although there are a number of people, and I'm looking at faces in the room, who are benefiting and have benefited from the therapy we currently have, we can't stop here. We've got to do more. So I have some financial disclosures. Essentially, I do consult with some of the companies whose compounds I'm going to talk about, and some of the things I'm going to talk about are not yet FDA approved. When we think about kidney cancer, we can't think of just one disease type. And what I'm going to talk about mainly is clear cell kidney cancer. And Dr. Tanir, my colleague and friend who's going to be presenting next, is going to be talking about the non-clear cell renal cell carcinomas. So what is clear cell kidney cancer? It's essentially a tumor that looks a certain way under the microscope. That's how they called it this back in the day. We recently, or more recently, have found out that it has a mutation in the VHL gene in the large majority of individuals. And I also run a VHL clinic where we're trying to marry the knowledge from hereditary kidney cancer to non-hereditary kidney cancer to improve therapy. This is not to scale. This is a protein. It's 213 amino acids long, and for the scientists in the audience, that's mercifully short. It also has only 3 exons. It has sort of 3 parts to it, so it's easier to study than most, but obviously still hard to study. What it does is it essentially regulates the way the cell reacts to oxygen. So obviously oxygen is one of our lifebloods. We need oxygen, we need water, we need glucose. And our cells, if they feel like they have enough oxygen, they basically sit back, and VHL will then take a transcription factor, which tells the cell which proteins to generate, and it breaks it down. If you have low oxygen state, the cell will say, help, I need oxygen. VHL will step back. These transcription factors you see, HIF alpha and HIF beta, are going to come together, and you will get production of proteins like VEGF, which is a growth factor for blood vessels, and it does a number of other things. If you have a mutation or somehow inactivation of the VHL gene, you essentially have this ongoing process of these cells, now cancerous, who are saying, somewhat untruthfully, we need more oxygen, we need more blood, build me an infrastructure. And so what that infrastructure is when we think of cancer, we can't think of cancer as just the cancer cells. It's the cancer cells, which are in black here. In blue above, we have the stromal cells, which are kind of the glue cells. And then above those, we have the endothelial cells, or the blood vessel cells. And this triumvirate, plus other cells, generate this organ. It's really an organ we call cancer. And when we use therapies, we're blocking specific areas there. And I'll tell you a little bit about the therapies that we use now, and then some of you are on, and where they're actually blocking. So just some terminology, which you've probably already heard, because I'm going to go through some jargon about trials, because that's what I'm supposed to do, and about therapies. Progression-free survival, or PFS, is the time it takes from when you start therapy to the time that the tumor starts growing again. Overall survival, in most of the studies I'm going to talk about, is the time from when the patient started the therapy to the time the patient passed away for whatever reason. So the blood vessel starving or anti-angiogenic therapies that we currently have available, of which there are 5 that are FDA approved, are listed here. And I'm going to go through these in detail. We also then have some up-and-coming drugs. And the way these drugs work is essentially they block the blood vessels. They try to kill the blood vessels of the cancer. They don't seem to have much effect on the cancer cell itself, which is why many of you may have experienced the fact that we can shrink this down, this cancer, but we can't make it go away. And what we need in our wish list are kidney cancer cell killing therapies for the future. The mTOR inhibitors, of which there are two, there's Toracel and Afinitor, or temsirolimus and everolimus. What they do is they're actually working inside the cell, both perhaps the cancer cell and the blood vessel cell, and they're blocking particular proteins that seem to be upregulated, overexcited in the cancer cell that gives them a selective growth advantage. And so essentially we have there on the bottom in kind of a yucky brown color mTOR, and that, if it's overactivated, results in more protein production and more survival signals for the cancer cell when it shouldn't have it. And what Toracel and Afinitor do is block that signal. So let's talk a little bit about the drugs that in 2012 we're currently using. The one that's probably still most commonly used for most individuals is Sutent or sunitinib. And what this is, it's a pill. It blocks those blood vessel cells. It doesn't seem to block the cancer cells that much. It's given officially 4 weeks on and 2 weeks off, although I don't remember the last time I prescribed it that way for anyone. I tend to start 2 weeks on and 1 week off because I find people tolerate it better that way. And it was FDA approved now, amazingly, in January of 2006. That's a long time ago. But pretty amazing that we now still have some patients who are on it who started in January of 2006. So the reason this drug was approved was when it was compared to what was the old standard immunotherapy with interferon, what we saw is we saw a prolongation in progression-free survival, the time it took for the cancer to progress. And this was doubled, essentially, 11 months versus 5 months for interferon, which some of you might remember. It's a shot that you give under the skin 3 times a week. And the top line here is the line of individuals where they were progressing on Sutent, and the lower line is the line for the people who are progressing on the interferon. This is now what are called the overall survival curve. So essentially what we have here on the bottom line is time, and the top line is the number of individuals that are still alive. And what we see is the yellow line on top are the people who are on Sutent, the lower line are the people who are on interferon. It may not look like a huge gap between the two, but what's happened in these research studies when we do them is there's what we call crossover. So when you progress on one of the drugs, you get onto another, and another, and another. And the good news about that is it raises up everyone's survival expectation to some degree, but it makes it harder to say, well, that one drug is the one that's really making a difference. Until we actually get therapies that consistently and reliably cure kidney cancer, we're still going to be facing this dilemma of having incremental benefits. But hey, we'll take them. Another drug that's come out and has been used since 2009 is Votrient, or pazopanib. It's another oral drug given daily, once a day. Same sort of thing, a blood vessel blocking agent. This was tested in a slightly interesting study where you had patients who either had no therapy before or one therapy before, which had been immune therapy, and they were randomized, randomly allocated between the Votrient or the pazopanib and placebo. And I have to say most of the people that were enrolled in this were enrolled in non-US sites because it was a little bit of a hard sell for people. Look, you've not had any therapy before, but we're going to put you on placebo maybe. Nevertheless, the trial was accrued to, and it demonstrated that there was a very significant improvement in the progression-free survival, the time to progression, in the individuals who are on the Votrient compared to the placebo. And what we see on the left-hand side here is we see one of these tables again, or charts, showing that the orange line on top were the people who still remained free of progression over time, and the lower line, the people who are on placebo. And the progression-free survival data for people who had not been on prior therapy was as good as we had seen with Sutent. Now we have a trial that's currently completed and is being analyzed to see whether or not Sutent's better than Votrient. We still don't know which one's quote-unquote better. But Votrient certainly has been gaining traction because of the fact that it looks kind of promising. Now, what's interesting is when they did overall survival analyses here, they did not succeed in showing a big difference because a lot of people had gotten onto Votrient when they had been on placebo initially, and they got onto all sorts of other drugs. So the next drug that we're going to talk about is a little different, Avastin. What Avastin is it's actually an injectable antibody against the thing that the cancer cell produces, the VEGF, circulating in the circulation. And it tries to take it out of circulation so that the blood vessel cells can't see it. It's given every 2 weeks. Officially, it's given with interferon 3 times a week, which makes it a little less attractive for some patients. And this is kind of busy, but the bottom line was that the progression-free survival for this drug in combination with interferon was, again, substantially better than interferon alone. And this was done in 2 different studies, and the data were both true in both of these big studies. So pretty confident that this definitely, along with Sutent and Votrient, prolongs progression-free survival. In terms of overall survival, and what I've done is I've circled here what the people on the left on this row that's circled is the overall survival, 21 months, for the interferon group. On the other side, then next to it, are the interferon plus Avastin people who had 23.3 months. Again, in the same ballpark as we were seeing with Votrient and Sutent, not a statistically significant difference. The statisticians take these numbers and crunch them and look at p-values and things like that. But still, there was a lot of crossover here, and if we look at historic data, we're clearly moving up the bar here. One of my favorite data pieces now from Sutent was that in individuals who are on that Sutent study who had received Sutent or interferon, a lot of these people were treated in countries where there were no opportunities for second or third line therapy. So basically all they got was either Sutent or interferon. And the people who were on the Sutent arm only and got nothing else had a 28-month survival. The people who received interferon had only a 14-month survival. So that's kind of an unsort of tarnished set of data showing the magnitude of benefit that we're seeing. And I think that's more reflective of what we are seeing in our clinics today. This is now, I won't go into this in detail. Bottom line is, it's a lot of numbers and you're probably getting numbered out. Bottom line is we look at historic data for people who are treated compared to people who are on these drugs and then get subsequent drugs. We're seeing survivals that are in the 2 to 3 to 4 years. The next drug we're going to talk about is Savar, which was approved again in 2005, the first of these drugs to be approved. Same deal. This is a blood vessel starving drug. It's given twice a day. It was initially tested in people who had not received any targeted therapies before but had progressed on immune therapy, and it demonstrated that there was an improvement in progression-free survival again. And if you looked at overall survival, the improvement was there if you took out those people who crossed over. So again, modest improvements and definitely doing something for patients. Now, when this drug was then compared directly in the untreated patients to interferon, what ended up happening was it didn't look like it was better than interferon alone. And I've just finished telling you that Sutent, Votrient, Avastin all beat interferon. And here we have a drug that seemingly didn't. Subsequent studies have been done with this drug, Savar, where that progression-free survival does seem to be better than this trial. But in reality, in 2012, this drug is not used that much in the frontline setting, for better or for worse. Maybe it should be, but it is not commonly used, and I personally don't use it that commonly based on these data. What I've been talking about up until now have been individuals who have clear cell kidney cancer, who have what we call good risk features. And these are features essentially looking at, are you anemic? Is your calcium elevated? Are you feeling sick? Etc. And these are risk factors that we use to decide on whether a person's kind of in a good or intermediate category versus in a not so good category. And Toracel is a drug that's an Mtor inhibitor, which I was talking about before, which was tested in this poorer risk population of patients. It was FDA approved in 2007. And essentially what they did here is they took patients who had not received any prior therapy and they checked boxes. They said, all right, do you have a low performance status in terms of your good feelingness? Is it lower? Do you have you had your kidney removed before or not? Have you had anemia? Have you had high calcium? Is your LDH elevated? 6 categories in total. If you had at least 3 of those negative categories, they said, all right, we're going to put you on Toracel, and we're going to then compare Toracel to interferon or interferon plus Toracel. And because we know that this group of individuals tends to have a lower overall survival, they did an overall survival study. And it's a little bit hard to see in the blue background, I apologize, but bottom line was this was the first drug that showed in poor risk category patients that it improved overall survival compared to interferon. Does that mean that Toracel is not good for people who have good risk features? Unfortunately, we don't have an answer to that because that study has not been done. But this drug was approved. We know for people who have poor risk features seems to provide benefit. Does that mean that Toracel shouldn't be used in the second or third line setting for people who have clear cell and good risk features? No, it doesn't. It simply means that those are the data we have. And realistically, in the second and third and fourth line settings, except for the data that I'm going to be presenting to you now, we kind of figure out, well, let's see, you've been on this, we've tried that, let's now try this. There's a certain amount of art to it as well as science. So let's talk about second line therapy. Afinitor was FDA approved in 2009 for individuals who had previously received either Sutent or Nexavar or both. And essentially this was a study. They basically said, all right, have you progressed on Sutent or Nexavar? Yes. All right, you get to go into the trial. You then were randomized, so a computer flipped a coin between the Afinitor or placebo, and we asked, well, what was the progression-free survival? And the bottom line was, compared to placebo, this was clearly better in terms of progression-free survival. And that's why the drug was approved. And it's one of the most commonly used drugs in the second or third line setting for patients with metastatic kidney cancer. The new kid on the block in the second line setting is Inlyta or axitinib. Dr. Brian Rennie presented these data last year. This was a large study looking at, this is another blood vessel starving drug. It's the next generation. It's more highly engineered to block only the VEGF pathway, and it does a little bit less of the other stuff, which in some ways might be a really good thing or maybe not so good. Sometimes you might want to have a little bit of, playing the field in terms of blocking things as opposed to being something super targeted. So what do the data show? So this was a study. People had previously received one of these drugs, Sutent or Nexavar, got randomized to Inlyta or Nexavar. And then they looked at the progression-free survival. And the overall progression-free survival was longer in the Inlyta or axitinib compared to the Nexavar, about 6.7 versus 4.7. Now, what was interesting was this was a group of individuals who had received either these drugs, these targeted drugs before, or who had received immune therapy. And this shows it nicely in table form, but I'll just tell you what it shows is that if you had received prior immune therapy, the Inlyta or axitinib was way better than the Nexavar. If you'd received prior targeted therapy, same class as the Inlyta and the Nexavar, the differences were not that great. So it's better than Nexavar in people previously treated with Sutent, for example, but it's not incredibly better. Nevertheless, it's a good drug, it's a fairly clean drug, and it's a very welcome addition to the drugs that we have available. And we're using it, and we're finding that we're getting some good results. So up-and-comers in the last few minutes, tivozanib. is another one of these blood vessel starving drugs. So now we've got 1, 2, 3, 4, 5 that are approved. This would be number 6 of the same class. And like other classes of drugs, it's always good to have gradual improvement. It's a pill form drug again. It does the same sort of thing, blocking the VEGF pathway. And there were some phase 3 data, so a big clinical trial that was performed showing that it does actually seem to do better than Savar it was compared to. So it's probably coming down the pipeline as an approved drug in the next year. Now what's interesting about all of these drugs is the newer the drug, it seems the lower the side effect profile because they're getting better and better at engineering these. So we're getting a refinement of a class of drugs, at least in the blood vessel starving arena, but it's not dramatically different, and we need something dramatically different. So what about combinations? So in oncology, in cancer therapy, cancer doctors love combining things. Well, you have drug A that works okay, you got drug B that works okay, let's combine it and we'll hopefully get a duplicative effect or an additive effect. Hasn't really happened, unfortunately. Bottom line, combinations at this point in time have not really consistently been shown to be superior to single agents. You get more side effects, you don't necessarily get more survival or better bang for the buck in terms of progression. Sequences is what we really do. So sequencing means you start with drug A, you move to drug B, you move on to drug C. That's what we do in the clinic. And one of the trials Dr. Tanier has championed is the START trial, and we have now 80 to 90 patients on this. We're looking at, well, if you start with Votrient or Afinitor or Avastin, and you then progress and you get re-randomized to one of the remaining drugs, does that provide you any benefit? And there are other trials like that that are undergoing. The SWITCH trial, which is going on in Europe, starting with Savar, followed by Sutent, Sutent versus Savar. Record 3, Afinitor followed by Sutent, Sutent followed by Afinitor. We're trying to figure out whether there are sequences that work better for some patients than others. So this is the big table that my former mentor, Dr. Michael Atkins, put up a form of in 2006, and it's been gradually refined over the years. So the bottom line is we have favorite drugs for untreated patients in the first-line setting. We've talked about immunotherapy before lunch, and Dr. McDermott talked about interleukin-2 and other things. We have our blood vessel starving drugs for that category as well. In people who have poor risk features, we have Toracel. In the second-line setting, we now have good data from these trials that show that Afinitor and axitinib probably provide a benefit after failing these other drugs. And we have ongoing studies trying to figure out whether or not one sequence is better than the other. But this is nice, and we're making real strides, but what do we really need to do? So coming back to this picture of the cancer, we're good at kind of hitting the red part. We don't know exactly why, when these drugs are used, why do we start developing resistance after 10 months or 12 months or so? Why can't we kill the cancer cell? So what we need is we need new drugs that can block other receptors in those blood vessel cells. We need agents that can actually kind of fix, look under the hood of the cancer cell, see what's broken in there, fiddle with it, and maybe make it start behaving more like a normal cell. And if we can't do that, kill the cancer cell. So agents that block novel targets in the blood vessels. So what we're looking at is new receptors on there and seeing whether or not those drugs, in combination with some of the other blood vessel starving drugs I've talked about, are useful. I'm part of a nanomedicine development grant where the hypothesis, the idea here, the big idea, is that a lot of the VHL proteins that are mutated are kind of wounded but not dead. And if we can kind of revive them, we can maybe make the cancer cell behave more normally. And one of the ways to do that is to raise the level of VHL. And we're going to be testing a drug called carfilzomib to actually validate that. The last thing is those agents that actually can kill the cancer cell. And this, amazingly, in 2012, is still kind of in the experimental stages. We have a colleague over in Stanford, Amato Giaccia, who's done some of these screens, has come up with some interesting ideas. I know that people at Harvard and around the country, and we as well, are looking at this strategy. We've got to try to find something that actually kills the cell. And we have to perhaps stop focusing as much on getting yet another blood vessel starving drug. So an example of a drug that might be doing this to some degree is a MET inhibitor. So MET's another protein that's found on the surface of the cancer cell. And there were some reports at GeoASCO that this might be a promising avenue. So in summary, I think we're getting really good at blocking the VEGF pathway. We've made real inroads in overall survival for patients with kidney cancers. No question about it. Mtor inhibitors also do a good job. We kind of know where to use these, but we're learning more about it. We've got to figure out why resistance occurs and how to overcome that resistance. Participation in clinical trials is key. We also need to find drugs that can kill the cancer cell directly. I'll end there. Thank you very much.